Good. So what do you know about shock?
I just know that there's different types of shock, and basically, you it can happen through different types of reasons. You can have like shock induced, like due to the fact that you have no like the decrease in blood volume, so like hypovolemic shock. You
Mhm.
can have like things like sepsis, where like different types of infections can cause massive like vasodilation. So
Mhm.
you just lose that way. Um, you have cardiogenic shock, where like the heart is just unable to
Mhm.
similar to like, yeah, similar to heart failure, but like I guess more pronounced, in which the body can't supply anything to the rest of the body. The heart can't supply it, so that's cardiogenic shock. It's most for the most part just like a decrease in blood pressure, like significant decrease in blood pressure due to whatever reason.
Mhm. Great. So we could say that the definition of shock is body organs are not getting enough blood. It could be due to heart
Mhm.
issue or vessel issue. Because what's giving me blood is the cardiovascular system, the heart and vessels. That's it. We
Yeah.
have four types of shock. We would be getting into it. This PDF is annoying. Good. Great. So please solve this case or tell me what you think of this case.
Yeah, so a 30-year-old woman, significant mechanism of injury, unconscious, intubated ED, blood pressure 64 over 40, heart rate is 162, and ventilated, CG diminished left brain sounds. Unstable pelvis, despite fluids, the fully minimal, still pink color, extremities are cool and clammy. Now the abdomen is tense with decreased. Now the abdomen is tense with decreased bowel sounds. I mean, yeah, it's most likely due to like a hypovolemic shock, some kind of injury that she obtained. Her blood pressure is exponentially like decreased. The heart is attempting to compensate by increasing the heart rate, but along this you have the basically the body is going to try to compensate blood supply by kind of shunting the blood towards the important organs. So that's
Mhm.
why you have for so you have like extreme like peripheral um what's good like constriction or like vasoconstriction, which is why the extremities are
Mhm.
cool and clammy. Um
Because the
and
skin is not very
then
life-saving organ. It's not very important. So
yeah,
yeah, the
yeah,
first
not
organ
needed.
that I would be taking blood of is the skin. Yes.
Hmm.
Great.
The
So
only thing I'm not really too sure on what's happening is the abdomen. I guess it's just kind of you're not digesting, like it's not spending time digesting, so that's why you have decreased bowel sounds.
could you repeat what you said?
Yeah, so I was just saying that I'm not entirely sure what the issue is with like the abdomen. So like I don't know why the abdomen is tense or why there's decreased bowel sounds. I'm assuming it's just because like the body's in a state of like fight or flight, so everything that's used for digestion and all that is decreased.
No, no. Normally, you wouldn't have a tense abdomen. Tense abdomen, by the way, equals surgical abdomen.
Surgical abdomen.
So in the ER, when I have an emergency, how to know this patient need an emergent surgery? It's tense abdomen. Tense.
A tense. Okay.
So if it's tense abdomen, then I'm having a disaster. I'm having like
Mhm.
a visceral perforation. I'm having like severe bleeding, severe intra-abdominal bleeding. So it's
Gotcha.
tense. By the way, there is a difference between tense and rigid. You know it? Tense and
Tense
rigid.
and rigid? No,
Yeah,
I don't
rigid,
know the difference.
rigid. When like I'm examining the patient and my hand is very cold. So if I touch his abdomen, he would be like making it rigid. So rigid is like a voluntary behavior. So patient could be
Yeah.
making his abdomen rigid. It's a voluntary behavior and it's very normal, by the way. Maybe my hand is cold. Maybe he's a child and he's afraid of me. It has many different causes. But tense mean it's involuntary, rigid. It's something that's involuntary.
Gotcha.
Even under
Yeah, that makes sense.
anesthesia, it could still be tense. But you know,
Yeah.
you don't care about anesthesia. So tense means this abdomen has a disaster. It's mostly intra-abdominal bleeding. So that's why his blood pressure is dropping and heart rate is high. It's mostly intra-abdominal bleeding because this patient has a mechanism of injury, probably motor vehicle accidents that has caused him to be having unstable pelvis. You know, it's pelvic fracture. So it was severe abdominal trauma. So yeah, it may be causing like
Gotcha.
yeah, a rupture of any main vessel like renal artery or something. So yeah, that's it. Good. It's a shock for sure. It's
Yeah,
a
no,
shock.
that makes
So
sense.
I have the main sign
Yeah.
of shock, which is increased heart rate and decreased blood pressure. So yeah, it's a shock. The cause of a shock, it's hemorrhagic shock, or we call it hypovolemic shock. And hemorrhage is in the abdomen.
Yeah.
Great. So what's the primary cause of a shock? What do you think?
Yeah, the intra-abdominal hemorrhage, most likely due to the injury.
Yes. And I'm sure it's an intra-abdominal injury because it's tense abdomen.
Tense abdomen. Yeah.
For sure there is bleeding.
Yeah.
How I know it's intra-abdominal? Because it's tense abdomen. Great. Almost any pelvic fracture patient would be having intra-abdominal hemorrhage because, you know, pelvic area has a lot of blood vessels, iliac arteries, you know. So for sure, this trauma that has caused fracture, it would be causing some sort of vascular injury.
Okay, that makes sense.
Great. What's shock?
Yeah, just kind of saying what we were discussing before, just the body not being able to supply, or the heart, you know, just in general, the lack of tissue perfusion, or like lack of blood supply to the tissue.
Great. So it's inadequate perfusion or inadequate delivery of oxygen to meet tissue demands. So tissue would be making anaerobic metabolism because I don't have oxygen, then I'll be shifting to anaerobic. Cellular dysfunction and maybe cellular this. So this is failure. And maybe all the patient would be dying. So if someone is in shock and he haven't got appropriate medical attention, he would be dying for sure. Okay, pick the 4 main types of shock.
I know we have hypovolemic shock. I know we have cardiogenic shock, obstructive shock, and I guess anaphylactic.
So you think anaphylactic is the 4th type?
Yes.
Why not distributive? Why do you think it's anaphylactic?
Just because I've heard of anaphylactic shock, but I haven't heard of distributive shock. So
there is something called okay. So you know, we have something called hemorrhagic shock. We have just discussed it. This female patient is in motor vehicle accident or in a mechanism of injury.
yeah.
Hemorrhagic shock. So you think it's one of the 4 types, hemorrhagic shock?
Yeah.
No. Let me
It's
explain.
not?
Yeah. We have it's a 4 main types. Types of shock are you know, it's a big number of types, but we have 4 main types that other types would be falling under them. So I have a big name called hypovolemic shock. So it's the volume of blood is low. It may be due to dehydration, vomiting, or something. It may be due to hemorrhage. So the big name is hypovolemic shock. Another big name is cardiogenic shock. So it's a cardiac issue, whatever it is. It's a cardiac issue.
Yeah.
So it's a volume issue. The volume of the blood is low. It's cardiac issue. The heart is failing. It's an obstructive issue. There is something obstructing the blood to get out of this heart. By the way, what are examples of obstructive shock?
Would that just be like a stroke or like a pulmonary embolism where you just have no?
Yeah, pulmonary embolism is one. Yeah.
Okay.
Then
pulmonary embolism. What's another one? What causes massive, just like amounts of?
so it's like it's obstruction to the outflow of this heart. This heart couldn't be pumping. It's compressed from something. It's obstructed in this way. Cardiac tamponade is a type. Cardiac tamponade. So tamponading would be pressing on these vessels to the heart and pressing on the heart itself, so it wouldn't be able to push blood. So cardiac tamponade is another
Gotcha.
example of obstructive shock. Yeah. So
Okay.
obstructive is the big name. Cardiogenic is the big name. Also distributive. So it's the fourth type. It's the big name. And under it, it could be causing septic shock, anaphylactic shock. They are all sorts of dilatation of vessels. It's called distributive.
Yeah.
If it's very acute, it's anaphylactic. If it's due to infection, it's septic shock. You know? So distributive mainly it's redistribution of blood rather than getting into target organ by a vessel. So this vessel normally deliver blood to the target organ like the liver, for example. So we have some blood right here in the vessel and some in the organ itself. Distributive means redistribution. So in distributive, I would be having no blood in the organ. Why? Because all this blood,
it's not being distributed to
it's distributed in the vessel. It would be more wider vessel, so it would be having all the blood, and this organ would be having nothing. It's distributive. Okay, so know that the main ones: distributive, cardiogenic, obstructive. You know, it's a very badly written lecture, but I'm trying to make it like the four main types are very important. Yeah, I'm trying to focus. Yeah, you have to know the four main types and know what are the causes of each one. So obstructive, you have to know BE and cardiac tamponade. Cardiogenic, you have to know, you already know it's heart failure. And if it's causing shock, it's acute heart failure, not the chronic one. It's mostly acute heart failure. Distributive, you have to know septic and anaphylactic. Hypovolemic, you have to know hemorrhagic and dehydration cause. Good. Okay. How to know if someone is in shock?
I just kind of thought it was just due to the blood pressure. If the blood pressure is severely like decreased, I would assume that they're in shock, and like if they're experiencing like those symptoms of just no perfusion or like the cool and clammy skin. That's what I would assume. It's just blood pressure plus signs and symptoms.
So if like for me as a medical intern, one of my main roles is following patients, following patient vitals to know if someone is going into a shock or something, to just pick it fast or pick it before things are bad.
Yeah.
I've learned very well that I shouldn't be depending on blood pressure. If a blood pressure have just dropped, then the patient have got into shock already. The patient is actually in late stages. Before blood pressure is dropping, when I can't be delivering blood to the target organ very well, the heart would be increasing its rate. So I have been focusing on heart rate. Yeah.
Gotcha.
The heart would be increasing its heart rate just to keep blood pressure normal. But after a little or a couple of minutes or maybe hours, this increased heart rate would be failing. So I would be having decreased blood pressure. So it's a late sign to see a decreased blood pressure. Firstly, I would be seeing increased heart rate. That's why I always, when I'm suspecting this patient is not very well, I'm counting heart rate with my hands. Not, we have electrical oximeter, pulse oximeters, it's not very accurate. Yeah. Heart rate is very important. You could be catching a patient in going into shock or something by just heart rate. It would be very great. And you could help him in this stage, in a stage of increased heart rate. He's still a good patient, but if it's decreased blood pressure, he's in the elite stage. You wouldn't be helping him very much.
Okay.
Good. So shock, like heart failure also, it's compensated. I mean, sympathetic system have just making increased heart rate. Yeah. So it's compensated. So firstly, it would be compensated. After some time, it would be uncompensated. And after a lot of time, it would be irreversible shocks. So these patient organs have failed, have dead, So Even
Yeah.
if you fixed it, he wouldn't just get back,
The damage is already done. Yeah. Yeah.
Yeah. And if you depend on heart rate, then it's in the compensated stage. The increased heart rate have compensated it to normal blood pressure. That's the stage I want you to pick the patient in. If blood pressure have
Gotcha.
just dropped, you are actually in or uncompensated stage,
Yeah.
We are not compensating. We are getting lower blood than normal to the tissues. So you have to focus on heart rates. Very important.
That makes sense. Yes.
Great. So it's telling you that hypotension is a late sign of shock. You know, um, heart rate increase to compensate, and the patient maybe till this point is compensated. It's good. Just little drop in blood pressure. Right here it's decompensated.
Gotcha.
Yeah, it's compensated to this point. Decompensated right here. What's compensating? It's the increased heart rate that has happened over those couple of hours.
Mhm.
Don't wait for hypotension. It's very important. Good. Okay, so physiological changes to blood loss. Blood loss could be causing a shock. If I have just lost 10% of my blood, so by the way, it's very normal to lose 10% of your blood. Blood donation, we are getting 50 millimeters of your blood,
Hmm.
which is actually 10%. And it's very safe to lose 50 milliliters. That's why we could be getting it from anyone donating blood. Because
Gotcha.
your
So it's any blood donation.
yeah, it's compensatory mechanism. Your compensatory mechanism by little increase in heart rate and systemic vascular resistance would be just enough to make you compensated and you wouldn't feel anything. Just a little blood or a lower amount of blood would be reaching to your baroreceptors, so it would increase your heart rate and increase your vascular resistance, and you would be compensated very much. But when you lose more, like 20, 30%, you are in danger. Because the heart rate increase and systemic vascular resistance increase wouldn't be compensating enough. And you would,
Compensation is not working anymore. Gotcha. Yeah.
yeah, you would have drop in blood pressure. And by the way, there is something called Bancroft-Edholm reflex. What's it? When I'm shocked, when I'm fainting, shocked, my muscles would be relaxed. This relaxation would be
Mhm.
decreasing systemic vascular resistance a little, and would be, it's like decreasing my compensation mechanisms.
Yeah. Yeah.
Yeah, when I'm yeah, I've choked, I really shocked or fainting, so I've lose muscles. I have like relaxed muscles. When it's terminal stage, the patient have lost more than 30 or 35 of his blood. He's just like dying. When a dying person, you have seen dying person in a movie or something, when
Yeah.
he's like being like dying, he's moving it's it's moving in a I don't know what to say, in an exaggerated manner. It's the same thing happening.
Mhm. Oh, yes, 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 yeah.
Yeah, sympathetic storm. It's exaggerations. We are dying, so we are pushing a lot of adrenaline and noradrenaline, so it could be increase in heart rate, great increase, and increase in systemic vascular resistance, but it's a late stage. And it could be keeping for a couple of minutes or hours your blood pressure, and yeah, but it wouldn't be handling things for a lot. It would be maybe minutes to hours. Do you have any question?
No, so far I'm okay. I'm understanding.
Okay. Mean arterial blood pressure, or
The difference between like your what is it, your systemic or no, your systolic and diastolic?
no? So,
Mm.
in my heart cycle, I have, for a normal person, you have 120 millimeter while your systole and 80 millimeters during your diastole.
Yeah.
That's your blood pressure. Mean, I
Mhm.
mean, by mean, I mean the average blood pressure, the average blood pressing to the organ, or the average blood reaching to the organ. It's around 90s, you know?
Around 90. Okay.
Yeah. Not exactly 90, but it's around 90. You know, it's the average, the mean between both of them. And it's mean arterial blood pressure, it's normal when you are fine, when you have preserved autoregulation. When you are shocked, it's greatly decreased.
Decreases.
When you have hypertensive emergency, it's greatly increased. Just, you know, it's uses slide, but yeah, I have to okay. This is very important. This is very important. So
Mhm.
when we are in shock, or we are getting into shock, you know, your body is not having enough blood to give every organ what he needs. So he would be cutting blood, causing a vasoconstriction on vital organs,
Yeah.
or sorry,
Mhm.
non-vital organs, the organs that's not important for our life, just to keep enough blood for the vital ones. Skin
Yeah, the important
is the
ones.
first one that would be getting vasoconstriction when I'm losing blood or I'm having any type of shock. Skin is not important to my life. So any patient that's have a coma or something, or have fainted, you would find his skin very cold and clammy because it's not getting blood. Skin. After skin, we have the liver. Yeah. In emergency, I don't need the liver right now. All I need in emergency is my brain to be working because it controls
And the heart,
everything,
yeah.
and my heart. But the liver, it's very important, but I don't need it in emergency situation. I could be, yeah, you know, I could be just stop having a liver for an hour and I wouldn't be affected. It's fine.
Mhm.
After it's planchenic and somatic, you know, my abdomen. Not very
Yeah.
important, yeah. I could be losing it for an hour and I would be fine. Renal is less important than cerebral and coronary, but it's important, yeah. If I'm not getting rid of urea and creatinine, I may be dying within a couple of days. But for sure, cerebral and coronary is the ones that you would be getting blood, whatever, you know, whatever your case. If blood stops from getting to your brain and the heart, you are dead. So I will be
Yeah.
closing blood to this, then this, then this, then this. If this one, its blood is closed, then I'm dead. That's it. You have to remember it very well. You have, and for sure, you should know that the skin is the least important one, and the most important is the heart
Mhm.
and the heart and the brain. That's it. Okay. It's baroreceptor compensation. You know what first feels that my blood pressure is dropping? It's baroreceptors. So it's
Mhm.
very close to the heart. So if I just my blood pressure is little dropping, those baroreceptors would be feeling it, and they would be sending an impulse of the heart to increase its heart rate. That's compensation. But after I'm losing more blood, then this increase in heart rate wouldn't be compensating because I've lost a lot. That's
Yeah.
so first we by having compensation, then it's decompensated or uncompensated. I believe it's the most useless slide I've ever seen. You know, uh, it could be he could be asking you about these concepts, but it's not important. You know, if I don't know what's chronotropy or something, I would be treating patient very well. You know, it's
Yeah.
not clinically relevant by any means.
Not yeah, exactly. Yeah.
Yeah. So chronotropy. Chrono means time. It means that the time for the heart to contract is less, so it increases heart rate or the rate of SA node firing.
Mhm.
And here, the most important receptor is funny sodium channels, which is in the SA node. By increasing sodium influx, it would be having increased rate. something else called dromotropy. Dromo means conduction. Conduction velocity, it's conduction between the atrium and ventricle, the AV node. And it's depend on L-type calcium channels, late type calcium channels. Increased calcium influx would make it a faster AV node conduction. Inotropy, ino means force. It's increased force of contraction. And it also depends on L-type calcium channel. It's mainly in the ventricles, like the AV node in the ventricles. It's force of contraction of the ventricles. Increased calcium influx, and ryanodine receptors have a rule, you know. By the way, I can't remember all of them, you know. I know almost 3 of them.
Yeah.
I know these 3, and I don't know anything about those 3, you know, and it's fine.
Yeah, no. Not needed
Inotropy
for actual practice. Yeah.
means increased force generation. It's a little different between conduction and heart rate, force generation. So, you know, it's the conversion of electricity, electricity to a force, to a mechanical contraction. That's kinetropy, speed at which force developed during contraction. And depending on myosin ATPase, zentropy, rate of myocardial relaxation, you know, and depend on something called, I've never seen, you know, I have never heard of this. Phospholamopan. Okay. Spasmotropy, increased excitability. So it's easily excitable, independent of voltage gated sodium channel and calcium channels. Yeah. Okay. That's sympathetic compensation. So sympathetic is acting on beta 1 on the heart, alpha receptors on the blood vessels. On the heart, it would be making it increase heart rate first, so it's chronotropy. Inotropy, increase force of contraction.
Yeah.
It's increasing all the parameters of the heart. So it would be increasing a stroke volume, and it would be compensating at first. In periphery, it would be increased vascular resistance. It would be increasing vasoconstriction. So the blood vessel would be turning like this. It would be much narrower. So that it would, you know, if it's narrower, then its blood would be moving like forward to the organ, not stagnant blood.
Okay.
You know, RAS system, we have talked about it more than
yeah.
RASS. So if I'm in a shock, I'm doing vasoconstriction of renal arteries, my kidneys is not getting enough blood. So the kidney is feeling like, you know, so if I'm not getting enough blood, then the blood volume is low. Then let's increase blood volume by increasing sodium and water retention. That's the main target of RAS system. So RAS system would be increasing sodium and water retention and doing some sort of vasoconstriction also. Aldosterone would be doing just sodium and water retention, and angiotensin 2 would be doing both retention and vasoconstriction. Also, my brain would be feeling, if we have hypotension, my brain wouldn't be getting enough blood, so the osmoreceptors would be feeling that our blood has, you know, slower amount of blood. So if I have lower amount of blood, I will be having increase in osmolarity. So I have lost like fluids, then I have some amount of sodium and some amount of water. If I lost a lot of water, or if I lost a great amount of blood, I would be making sodium and retention.
So yeah, to try to compensate. Okay.
Yeah, it will increase osmolarity. I make sodium retention just to, you know, because water will be following sodium. You know it? So in urine, I will be making sodium retention just for water to follow it. If I don't have enough water to follow the sodium and I have a lot of sodium, no water yet, I would be increased osmolarity. This increased osmolarity would be pushing the brain to secrete ADH, which has another name called vasopressin hormone. It acts on two receptors, V1 and V2. It's antidiuretic, so it acts on the kidneys, and it acts on the vessels, vasopressin. We have two kidneys, so V2 for the kidneys,
Yeah.
V2 for the
V2 for
kidneys, and V1 for the vessels.
Okay.
Good. You remember
Yeah.
beta 1 and beta 2? It's almost the same.
Yeah,
We have
one
two lungs and
one
one
heart,
heart.
two lungs.
Great.
Yeah.
Okay. So for history and physical examination, how to suspect shock. First, I will be taking vitals. So it's the most, the most vital and most life-saving. Just when you see a patient, take vitals, blood pressure, respiratory rate, heart rate. Then I would be doing examination, like seeing his lower limb or his liver, but vital first. So vitals is very crucial. So after vitals, I would be doing examination. If I just found like lower limb edema, then it's some sort of failure, heart failure. This
Yeah.
heart is not getting blood from the veins to the arteries. This heart is failing. So it's just blood is keeping in the veins, and we have no blood in the arteries, so we have shock. And if it's lower limb edema, it's mostly right ventricular failure.
Right. Yeah. Makes sense. Remember.
Yeah, we have talked about failure in the previous lecture.
Yeah.
Also, if it's right ventricular failure, we would be having hepatomegaly, because blood is
Yes.
congested in the liver. It would be
In the
inside the liver, and the liver would be not just enlarged but also tender to touch. Also, if it's left-sided failure, then it would be its forward symptom is shock, and backward symptom is lung edema. Carly B lines and alveolar edema, bad sign.
Yeah, everything that we talked about.
Yeah. And if I have a patient with shock, I will be doing a lot of labs, because shock means organs are not getting enough blood. So the liver may be failing, the kidneys may be failing. So I have to make sure everything is working. Lactate, BNB for the heart, blood gases, liver panel, kidney panel, electrolyte for the kidneys also, blood culture, CBC, because it could be sepsis causing shock, So that's why I'm making blood culture. CBC because it may be anemia. Severe anemia could be causing shock, by the way.
Anemia can also cause shock? Okay.
Okay. BT, BTT, NINR because it could be internal bleeding.
Yeah, no coagulation.
Hemorrhage.
Gotcha.
Yeah, I'll be ordering maybe much more investigations. Even in underdeveloped or developing countries like Egypt, we order even much more investigations, because this patient deserve to it's a dying patient.
We treat it, to get everything. Yeah.
Pallor is a sign of shock. And sometimes shock, it could be increased redness or flushing. And what type of shock? So this patient could have shock. First one in pallor could be shocked.
Yeah.
And the second one could be also shocked. What type of shock could be in right here and right here? Tell me.
Okay, so for the bottom one, would that be more like your not undistributive, like whichever one was the not hypovolemic, what's the word? Septic shock, because you're having vasodilation of everywhere, which would cause the blood to stay in the extremities.
Yeah, it's distributive.
Distributive shock. Yeah.
Septic is a type of distributive. So the main title is distributive, and types of distributive is septic and
anaphylactic.
Anaphylactic, yeah. So it's distributive. And for this one,
maybe hypovolemic shock, so that you can.
It could be a cause, yes. Yeah, great. Right here, this patient have jugular venous distension. Here's the jugular vein is very distended. So what type of shock do you think
Right
he
side
has?
heart failure. Cardiogenic shock could be.
Cardiogenic. What other type could be?
Extension of the obstructive shock. Could that also
Yes.
cause?
Obstruction, yeah. This heart couldn't be taking blood, it's obstructed, and it's leaving blood in the veins. In the jugular, and the liver
Mhm.
would be enlarged, and lower limb edema. That's it. Great. You know, it's complicated. It's here's the lung, here's the pleura. We have a lot of fluid. It should be a thin rim of fluid. So it's pleural effusion.
Oh, you just it increased.
It could
Okay, yeah, that
be,
makes sense.
yeah, it could be hemorrhage inside the pleura causing shock or something. Maybe. You know, I can't diagnose a patient with just a picture. I need a history. So if it's a
Yeah,
motor
yeah.
vehicle accident and the patient got a trauma in his chest and we see this, then yeah, it's bleeding inside the pleura. We are sure. Right here, it's pericardial effusion. So it's a lot of fluid around pericardium. It should be thin rim of fluid.
Mhm.
This is pericardium, two layers, one on the other. Right here, it should
Gotcha.
be a video. Should be a video. This one should be a video. So he's seeing left ventricular function to be reduced. So the left ventricle is not working enough. So it's cardiogenic shock, decreased contractility.
Mhm.
Mm, it's inferior vena cava. We see it with ultrasonography. And inferior vena
Mhm.
cava, you know, give me it was great to see it. I've seen it a couple of times. Give me like an idea of fluid volume or blood volume. You know,
Superior
um,
vena cava. Okay.
yeah, blood volume. Yeah, it's very easy to see superior and inferior vena cava. So it's inferior, sorry, not superior. Blood volume. I see it through the abdomen. You know, I see it's in the
Through the
epigastric
abdomen.
region.
Oh
I put
yeah.
the probe in the epigastric region and see it. You know,
Oh
if
yeah.
I have hypovolemia, then all the vessels would be compressed. So the inferior vena cava
Oh
would be
yeah. Yeah.
looking
Makes
like
sense.
this. Would be looking like
Yeah.
this. So
Squished.
if it's collapsed like this, then this patient has hypovolemic shock. I don't know the cause. Maybe hemorrhage. Maybe this
Mhm.
patient have a lot of vomiting. Maybe have severe diarrhea. But what I'm sure of is that's hypovolemic shock. Good?
Gotcha. Yeah, that makes
Yeah.
sense.
Inferior vena cava is attached to the right atrium right here. Here's right atrium, and here is the inferior vena cava. Could you imagine it?
Yeah, I can imagine.
Great. I believe we are done today. So would be let's stop the recording and talk about